Good morning. It's great to see everybody here. Okay, great. So I'm going to get right into our session. Just as Laura said, this is going to be a startup session on the cost of zero-dose children, focusing first on the rural areas. And so just lay down the principle. The question is, are there diminishing marginal returns? Any economist would come in with the theory that as you get to 90, 95%, that of course the unit cost goes up. And so our presenters might challenge that. And if they do challenge that, they're up against an audience that's a little bit cynical. So let's have them try. We're going to have presenters from several sub-Saharan African countries. We're going to have Uganda, Nigeria, Somalia, and Ethiopia. And I think we're going to start with the Somali region of Ethiopia. And I'll bring up our first presenter, Fenot Associates. The floor will be yours. Laura, I'm going to do how many minutes?
Yes, 10 minutes.
10 minutes. 10 minutes. I'll warn you when you have 1 minute remaining, and we'll hope you'll finish in 10.
Good morning, everyone. So my name is Fred Bobo. I'm from Fenot Associates. So our work looks at the cost of periodic investigation of routine immunization and mobile health and nutrition teams in Afar and Somali regions. So this work was through Fenot Associates and in collaboration with ThinkWell. Today I have here with me my colleague Azikiwe and Laura Afar. So Ethiopia is a home to over 1.1 million zero-dose children. So to close this gap, Ministry of Health developed accelerated action plan to address zero dose and under vaccinated children in Ethiopia from 2023 to 2025. So the action plan has several strategies to reach zero doses children, but the cost of these interventions is unknown. So our aim was to estimate the effectiveness and the cost of immunization delivery strategies aimed at reaching zero-dose children in rural remote areas. So we employed both quantitative and qualitative approaches. Our quant methods include activity-based bottom-up micro-costing study from health systems perspective. So cost represents volume-weighted average in 2024 USD. So to give you a bit of context about our study area, we included two regions, Afar and Somali regions. So these are nomadic pastoralist populations, highly conflict-affected areas, and most marginalized with limited access to healthcare and obviously very low immunization coverage and very high zero-dose children. So we selected 6 waradas, 3 from each region, 17 health centers, 32 health posters, and the study duration was from 2023 to 2024 November. So our qualitative study included interview with key informants across all health systems, from Ministry of Health to health extension workers, to contextualize post findings and understand potential operational, financial enablers and bottlenecks. So we evaluated 3 immunization strategies. The first one is routine immunization and regular outreach. So this is implemented by health centers and the health posters. So health centers provide facility-based services 5 days a week and conduct regular outreach program, while health posters primarily focus on outreach activities. The second strategy we evaluated was mobile health and nutrition teams. These are mobile teams primarily providing maternal and nutrition service in addition to immunization, and is focused in hard-to-reach areas. So they operate 6 days a week, uh, with one dedicated day per cavalry, and at times they look after the cavalries until they graduate, or key indicators such as, for example, stunting can't sufficiently be addressed. So this program is funded by the UNICEF, the vehicle, and the staff dedicated. And the third strategy was periodic intensification and routine immunization. This is a campaign style approach implemented from Warada or the administrative level with a strong community involvement. So according to policy, this is supposed to happen 4 times a year, but in reality, it's just happening 2 to 3 times a year, dependent on Gavi funding. So, looking at the interesting results of our analysis. So here you're looking at the estimated number of doses delivered in one Warda in 1 year. So, as you can see, health posters deliver the majority of all vaccine doses, but PIRI sessions are most effective at reaching zero-dose children. So, and if we look a bit closer at zero dose, 2 to 3 sessions of PIRI deliver or reach 646 zero-dose children, while the routine system or health centers and health posters, around 3 health centers and 60 health posters, only reach around 528 children. And looking at mobile health and nutrition teams, they reach fewer children, but they provide vast, important services such as maternal and nutrition services. So here we're looking at the economic cost of delivering the vaccination. So the major investment goes to the health posters. So 60 health posters in a year would cost around $21,880, while 2 to 3 sessions of PV take around $4,290. And the majority share of the cost goes to opportunity cost for mobile health nutrition team and routine immunization. So if we look at this, we break it down into sessions or a period of time. For in this specific instance, in a month. So periods are conducted in a session. One session period would cost around $1,607, while operating a health post for a month will cost around $114. And this is the economic cost of delivering a single dose to a child. So, if we look at the cost driver, periodization is primarily driven by the per diems, over 50%, and the mobile health and nutrition team. These are driven by labor costs and vehicle and fuel costs. And if we look at the routine immunization programs, these are mainly driven by labor and the cold chain maintenance at around 20%. So this is the answer to your question regarding how much it will cost to vaccinate a zero-dose child. So if we are looking into PIRI, the cost would be around $6, and mobile health and nutrition team 129. So when you look at it, you feel like maybe PIRI is cost efficient. But if you look closer, mobile health and nutrition teams provide a wide range of services, including maternal and nutrition services. So the specific immunization focused cost is only around 3.350 dollars. So you can see that mobile health and nutrition teams are efficient as well. So in conclusion, Both mobile health and nutrition team and PIRI are effective at filling operational challenges and resource gaps in routine system. But the key message here is these strategies must be complementing each other, and we should be looking out loud for resource overlapping as they reduce effectiveness. Our second key conclusion is that PIRI is the most effective and cost efficient at reaching zero dose children, even though it's conducted 2 to 3 times a year. And the issue is that children remain permanently behind in terms of getting the vaccines they needed. So the key thing or the message is referral linkage with routine have to be stronger. And the issue is because most parents they just wait for the next PD session to happen rather than going to a health facility and getting vaccine for their kid. And for the government to think about this, if they are thinking of maybe increasing, PD sessions, the cost efficiency would drop. And the final conclusion is that the immunization specific financial cost of mobile health and nutrition teams delivery is low, and it offers more comprehensive, consistent, targeted, and integrated approach to reaching vulnerable children. So, integration with other services are increasing uptake. Thank you so much.
Thank you, Fury. So maybe our hypothesis is under challenge. I think PIRI came very close to having a cost similar to her team. Let's move on. I know some of you came to see the drones. Unfortunately, the room's too small. We don't have drones for show and tell today, but we are going to hear Emmanuel Okello tell us about how drones could be a game changer in reaching zero-dose children, and he's going to present the results from Uganda. And we'll go and see the drones at some of their time.
Morning, everyone. I'm Emmanuel Okello. I'm a epidemiologist supporting the expanded program on immunization in Uganda. I'll be presenting to you findings from a study cost efficiency analysis of drone-based last mile delivery to remote island health facilities in Nnamdi district in Uganda. Last mile vaccine delivery refers to the final stage in the vaccine supply chain where vaccines are transported from the regional or district storage facilities to the endpoint of administration, often local health facilities. It is often the most challenging and costly part of the supply chain. Uganda's last mile vaccine delivery is multimodal, involving refrigerated trucks, motorcycles, boats, bicycles, and even delivering food. The challenges faced is in last mile delivery are often contextual, with each district having their unique ones. However, common challenges faced in Uganda include transporting vaccines over difficult terrains, challenges maintaining the cold chain, and navigating infrastructure, funding gaps, among others. Buvuma district, shown on the map, is an island district of Lake Victoria in Uganda, comprising of 52 inhabitable detached islands. It is divided into 9 administrative units, of which 8 are rural sub-counties. There are only 13 health facilities offering vaccination services in the district, with 4 being in the main island and 9 in the scattered satellite islands. These facilities offer both vaccination services, both at the static and outreach post. However, the district faces logistical challenges, including delayed or difficult last mile delivery of vaccines and post-that vaccine stockouts. which has subsequently led to poor immunization performance. In the first quarter of this year, the DPT 1 and 3 dropout rate was 32%, with approximately 6,000 zero-dose children. In Bovuma, the delivery of vaccines last mile, for this to happen, requested vaccines are carried by refrigerated trucks. From refrigerated trucks from the National Medical Store in Kampala City to the docking site in the neighboring mainland district, where they are carried across the lake by the ferry or boat, and then to the district vaccine stores. To deliver these vaccines to the respective health facilities from the district vaccine store for the main island health facilities, motorcycles or cars are used. For the satellite islands, either hired boats or Gavi boats are used. In this study, we propose drone delivery as an alternative last mile delivery model in Bovuma district, where requested quantities of vaccines are carried straight from the National Medical Store to the respective health facilities in the mainland and satellite islands. We did this with the objective of comparing the cost efficiency of drone delivery to the traditional multimodal transport method in the last mile delivery of vaccines in Bovuma district, Uganda. The study outcomes with the cost per vaccine delivered for both methods, and we took the government, specifically the health sector perspective. We fitted a decision analytic model using a MOA software with 3-month time horizon to simulate delivery of 13,000 childhood vaccines. 2 delivery strategies were compared: traditional multimodal transport to 70% probability of satellite of delivery to the satellite island health facilities and 30% the mainland health facilities, versus direct drone delivery using fixed wing or hybrid vertical takeoff and landing drones to each health facilities. The cost components included fixed and variable operational costs, which were amortized to either daily or quarterly costs. The table on the right is of the key parameters used in the model. We conducted a one-way sensitivity analysis to explore the impact of a plus or minus 25% variation in operational cost, and drew another diagram to illustrate the findings. Ladies and gentlemen, here are our findings. Drone delivery showed cost efficiency with a total cost of 6,412.5 compared to 14,055.9 for traditional transport, yielding a saving of 7,643.4 for the quarter 1. The cost per vaccine delivered was 1.08 per dose for the traditional transport and 0.49 per dose for drone delivery, yielding a cost of 0.459 per delivery. Sensitivity analysis confirmed robustness. Traditional costs range from 1.08 to 1.16 per dose delivered, while drone delivery ranged from 0.45 to 0.54 per dose delivered. Even under the most conservative assumptions, drone delivery remained more cost efficient. This cost efficiency analysis, while informative, had several limitations. It relied on modern data and assumptions specific to the Bovuma district. During one quarter of 2025, this limited its generalized ability to other areas or time period. The short analytic time horizon does not account for long costs like sustainable potential scale efficiencies. And also there is potential underestimation of indirect costs that were not amortized, such as indirect savings from faster delivery and wasted during transportation. Drone delivery. Drone-based vaccine delivery offers substantial savings compared to conventional logistics for reaching remote island communities. We recommend integration of drone technology into the Uganda's immunization supply chain, particularly for geographically isolated areas like Dodoma or Bishai. We also recommend further cost-effectiveness studies in the use of drone in vaccine logistics in the country, especially ones that expand analysis to improve the health outcomes, assess environmental impacts, and longer-term reliability. We are not in the following. Thank you so much.
Thank you so much, and thank you for sticking with time. So next year we'll see the drones. Okay, it looks like they're a cost saver. Our next presentation will be about intensifying treatment with additional outreach sessions, and that will be by Florence Sibeudu from Nnamdi University. Florence will give you the floor for 10 minutes.
Good morning, everyone. I'm Florence Sibeudu from Nigeria. So we are going to look at the cost of immunizing zero-dose children through additional outreach sessions in Kaduna, Nigeria. So introduction, with an estimated 2.1 million Nigerian children who have never received a vaccine. Nigeria is the country with the highest number of zero-dose children in the world. So this informed Nigeria trying to developing a zero-dose immunization recovery plan 2023 to 2028. And this implementation started with 100 priority LGAs in Nigeria. And outreach is a key element of this strategy. So study design scope is estimating the economic and financial delivery cost of routine immunization delivery strategies. So the perspective is a payer's perspective. So it's a bottom-up retrospective costing. So we use purposive sampling of priority LGAs in collaboration with state ministries of health. Then the time horizon is 1 month during data collection. And the main output is the average cost per dose delivered. So our study included 33 now facilities from 4 LGAs in Kaduna. Actually, we studied Jigawa, Kaduna, and Lagos, but this presentation is of Kaduna results. So then when implementing zero dose facility delivered more than, look at our findings. So okay, we have talked about Kaduna. We have 4 priority LGAs. Then the 3 facility, that is the one we selected. We have a rural setting too. So our findings. So if you look at our findings, monthly vaccine volume delivered, you see that the facility is not supported by any zero dose intervention. So you can see that it has average decrease in the monthly vaccines delivered, while the one supported has increased 47% increase in the volume delivered in the month. Then during zero to Z-drop, supported vaccine delivered more doses and reached more new children. You can see it from the slide. Then Z-drop facilities had 1,211. Then you also have the Delta 1 doses delivered 119. So taking it to 1,330. So, but the facility is not using a Z-drop. You have there's a marked difference between two of them. Then we have 91 doses per person in the catchment area, showing that when you come to the catchment area, you look at it, 91 doses delivered, it is better in Z-drop facilities than other facilities. Then the average cost per outreach session was higher at Z-drop facilities, and this is driven by staff incentives. They look at the financial cost per session. For other facilities, it's 12.05 dollars, while in a Z-drop facility is 25.18. So it's actually higher, but we know that it's because of the additional resources for the outreach. So when accounting for the increased volume delivered, outreach as Z-drop supported facilities appears to be more cost efficient. So if you look at for other facilities, we have seen this 12.05 before, but the Z-drop facilities, you will see that it is more efficient because the unit cost dropped to 0.25. Then the financial cost per zero dose children reached through outreach ranged between 1.72 to 8.24, but data was limited. Actually, we had challenge in getting data because of some data. That is because they don't have, some of the facilities may not have all the information we needed. So, but we tried as much as possible to get enough data. So what are the takeaways? Z-drop supports increase the number of vaccines doses delivered as well as the number of additional children reached with Penta 1. If Z-drop facilities increase volume delivery without adding many more additional outreach sessions, then cost efficiencies could be achieved despite additional financial expenditures. Recording of zero dose children which is heterogeneous. Further analysis is needed to determine the impact of funding and contextual factors. Thank you for listening.
Thank you, Florence. So we're gonna, our first three presentations were a bit of using blanketing strategies to reach zero dose children. When I say blanketing, it's doing something that benefits everybody. They could be zero dose, they could be anybody. The drone could help any child. PIRU session, a PIRU session could help any child. And here are these outreaches. We're not targeting. Now we're going to move to our last two sessions to target, to find that zero dose child first through screening and then intensifying that targeting. When you target, you could be more efficient because you're putting your resources on that zero dose child. So let's hear now about our targeting strategies. And the first presenter of those targeting strategies will be Carol Kamya from Uganda on health registration. The floor is yours.
Everyone. Good
Good morning, everyone. My name is Kamya from Uganda, and today I'll be presenting on behalf of the Zero Dose Learning Hub in Uganda, and the title of my presentation is The Cost of Identifying and Reaching Zero Dose Children, with a focus on house-to-house registration and targeted outreaches. So Uganda has made significant progress in improving immunization coverage with about 200,000 zero-dose children estimated. But despite this, there's an increasing number of outbreaks and an accumulation of zero-dose and under-immunized children. So in November 2024, the immunization program set out to conduct what they call a big catch-up campaign. And this campaign aimed to reach about 300,000 zero-dose children and 670,000 under-immunized children nationally. So we set out to estimate the incremental cost of identifying and reaching these children, implemented through the selected interventions implemented as part of the big catch-up campaign. And this is really because there's limited evidence on these costs, and previous exercises have mainly focused on estimating the costs of routine costs of immunization, as well as the mapping financial flows. So our costing study was retrospective in nature, and it took on an ingredients costing-based approach in 3 selected districts, and these were selected based on the burden of zero-dose children and also several characteristics of high-risk communities in these districts. We took on a payer perspective and focused on the cost per zero-dose child vaccinated as the primary outcome. So this picture shows one of the study districts, which highlights the sparsely populated communities as well as the geographical terrain that the health workers have to maneuver in order to implement these strategies. So in terms of results, the 3 districts that we focused on registered about 120,000 children, but 8% of these were zero-dose children. However, after registration, the health workers were supposed to then use the data to target outreaches, and they were able to vaccinate about 23,700 children. In Mubende and Wakiso districts, the number vaccinated actually went higher than those registered, and this was because of several implementation challenges. So this slide summarizes the registration costs across different cost categories, with the house-to-house registration having the highest cost, and this was mainly driven by personnel time and PDMs, as well as the data processing. So the Ministry of Health did not plan for data processing, and in some districts, implementation partners came in to support this data processing exercise because the village health teams who registered the households used paper-based forms, and this data was then transferred to a digital platform. So the registration costs, the cost per zero-dose child identified came to about $3 per child, with a range of $1.3 in Wakiso and about $6 in Kasese district. And then with regards to vaccination-related costs, these graphs summarize the vaccine delivery costs in blue and the vaccine costs in orange. The graph to the left summarizes the vaccine costs with relation to DPT1, and these are the zero-dose children. Kasese district in particular had a higher total cost of about 8,600, with the majority of the costs accounted for by vaccine delivery costs, even though they did not vaccinate so many zero-dose children. In contrast, for DPT3, Mubende had the highest total costs, and this can be explained by the higher number of children vaccinated compared to the other districts. So the cost per child vaccinated across all districts came to about $13, ranging from $8 to $68. And the $68 can be explained by Kasese district, which only vaccinated 124 children. And when you compare this to Mubende district that vaccinated 966, the cost goes down. So perhaps this kind of answers the question that was posed today. However, this big catch-up campaign had several challenges, and the main challenge around the registration of households was that only one village health team member or community health worker was engaged in the activity, and yet, as I showed you on one of the pictures, these communities are wide, and it is practically impossible for one VHT to register all households within their village. So, in other words, the registration was not conducted as planned. Additionally, the vaccination that was conducted by the health workers was not actually linked to the registration due to short timelines for implementation and other challenges, and this could have led to not all children being vaccinated in the context of staffing shortages as well as the resistance towards immunization in the communities. So there's a considerable financial investment that is required to reach these children, which is estimated at about $2.3 million. But this figure does not include the amount that is required to identify these children. Because the system that we have, the DHIS, does not offer disaggregated data, and as such, we are not able to identify or track the immunization status of these children, and this makes it a bit difficult. However, as we've seen, costs are dynamic and responsive to, one, the number of children who are actually identified, and also the number of children who are vaccinated, as well as the number of administrative units. As we saw, they had high costs, and this is partly because they have a higher number of sub-counties in the district, as well as the geographical challenges that the health workers have to maneuver. But integrating additional antigens into campaign-based outreaches can offer some significant cost savings, as we've seen. And as I highlighted, DHIS2 does not offer disaggregated data. So actually registering these households helped the health workers to identify the zero-dose children in the communities. As you can see, the picture on the right is one of the households that was visited. And these households tend to be secluded from the main towns. And in order to reach these children who are systematically missed by the health system, more has to be done. So some of the learnings are that village health team members are key players in identification of these children, because many mothers give birth at home, but to identify and track the immunization status, we need a data capture system that actually does so, because the zero-dose burden is a moving target. And the barriers, in order to address the barriers to uptake, we need tailored approaches. So what does this mean? It means that we need to leverage localized data in order to target outreaches, and this could actually reduce the cost over time, as well as accelerate the digitization of the immunization systems to identify and reach the zero-dose children. It also means that we need to leverage existing health platforms for integrated identification and vaccination efforts, and this could be through other immunization activities like child health days, or the introduction of new vaccines or other campaigns, and also leveraging on activities from other programs, which could be through malaria, HIV, TB. Additionally, for future efforts, it's necessary to allocate resources based on the local district-specific challenges, so that we account for those context-specific challenges, such as geographical barriers, as well as high travel costs. I wish to acknowledge everyone listed on this slide. Thank you for listening.
Thank you. I like that observation that we want to leverage existing CHWs. Why should the vaccine program pay for knowing what's going on with all the infants? That should be done as part of routine public health. And then the cost of getting that registration data and using it for vaccines would be more affordable. Our last presentation is similar, which is a outreach and catch-up campaign, and that will be coming from Senait Beshah from the Ethiopia Public Health Institute. We give you 10 minutes.
Good morning, everyone. My name is Senait. I'm from Ethiopia Public Health Institute, working as a researcher in economics. So our presentation is cost effectiveness analysis of routine in the mass campaign, measles vaccination strategy in selected conflict affected district in Ethiopia. To meet IHEA 2013, Gavi, WHO, UNICEF, and the other partners are working together to leaving no child behind immunization. This is a critical impact for ACDG. So as vaccine is a very cost-effective strategy to reduce poverty, household costs, and avert deaths, and increase life productivities. So addressing zero dose is important for ACDG as well. So the measles is a preventable disease, but it causes deaths in the deaths. As Ethiopia is high prevalence in zero dose, like 33% of zero dose prevalence in the 57% of unimmunized children, especially in low and the conflict affected region. This study aimed to analyze the cost and the cost-effective analysis of routine in the mass campaign strategy to give clue for policymakers since resource is scarce. So we select four very affected conflict district in Ethiopia from a huge region, Oromia in the Amara. And we apply full economic evaluation that assess both cost and the outcome. The cost, we apply cost framework with micro costing, bottom up, with provider perspective. Costs were estimated in 20-25 USD after we collecting Ember, and we estimate based on 20-25 USD exchange rates. We conduct decision tree model by Tried Pro software in 2025 Tried Pro software. Compare routine catch-up with this routine-based immunization activities in the mass campaign. We consider this a measles national campaign which held in May 14, 2024 in Ethiopia. The health outcome were assessed based on DALI averted, which is considered year of life lost in the year of life disability. Incremental cost-effective ratio sensitivity analysis, both probability in the one way was done. So during the measles vaccination campaign coverage, slightly higher than the routine one, but not much higher, but slightly higher in each conflict-affected district. Costs were conducted was economic in the financial cost. So the cost per dose were for financial 1.08 USD, whereas the economic is 1.73 for measles vaccination campaign at the conflict affected region. As the cost is shared, maybe it is lost cost, because the cost is shared during the campaign. The campaign will accompany both nutrition screening and the vitamins supplement, vitamin A and the deworming supplement. So we consider only for zero dose measles vaccination. That means the midst of there is children less than 24 months. This is the routine catch-up campaign. So the routine catch-up or similar is the least cost per dose, that is 0.89 for financial in the 1.78 or most similar to the mass combination. This is when investing 833 USD, we can vaccinate 809 children, and when invest in routine 703 USD, we can vaccinate 719 measles vaccinated children. When it comes to incremental cost-effective ratio, the incremental cost-effective ratio is 6.14. So in routine catch-up strategy, we can avert additional 3.05 dialysis. That means the incremental cost-effective ratio is 6.45. It indicates that the one dialysis could be averted in 6.45 USDs. So this is below Ethiopian GDP per capita. That is a very cost-effective strategy. The routine one is the cost-effective strategy to fall below the Ethiopian GDP capital, which is 118. The one-way sensitivity analysis indicates that when invest 3 USD for routine catch-up, we can avert approximately 77% of measles zero dose prevalence. The probability sensitivity analysis applies that when invest 2.50 USD, both catch-up in the routine campaign are equal chance to avert zero dose. Beyond 2.5, the campaign is less cost-effective compared to the routine one. The catch-up strategy is achieved being probability at 5 USDs. We conclude that Ethiopians continue to face high burden of zero-dose measles, especially in conflict-affected region. So routine catch-up vaccination is a cost-effective strategy to deliver better, since resource is scarce. Additional studies are needed to capture client side, both indirect and the direct costs. And the future evaluation should be included in undeserved population, to have internally displaced refuge areas, to equity in the comprehensive of cost effectiveness analysis. This is our collaborators. Thank you.
Things stay up here. We're going to have all of our speakers come up and have a session of questions and answers. So all of our speakers, please come up and have a seat up at the front.
Thank you so much for the questions. I have my colleagues here, so I will be sharing the questions with my colleagues. But to answer one of your questions regarding the virus cohort, so like if you vaccinate a child this year, and how, if they are addressed this year, what's gonna happen next year? So like, for example, in Ethiopia, with population rate of increase of around 2.5, and in remote areas such as Somali and Afar, there are always probabilities of missing children, and so like every year coming back out and trying to catch them up with vaccination is important. So that's one of the reasons on your question. And the other interesting question was how we did share the costs. I would like to invite one of my colleagues to talk on that. Up to you.
Thank you. My name is Azikiwe. I'm also the part of projects on the estimating cost of PIRI and the mobile team in Afar and the Somali region. Regarding the shared costs, we used the time dimension to know the specific time allocated for the immunization. For example, in the mobile health and the nutrition team, we first identified the total time allocated. For example, if they work 8 hours per day, and we asked them for how many time they allocated for the immunization. For example, it may be 1 hour per day for immunization, and the 7 hour can be for nutrition or any other activity. Depending on that rule, we allocated for immunization specific. But in case of PIRI, the intensification of routine immunization, it is only about immunization, so there is no shared costs. Thank you. And in addition to the impact, someone from the conference asked about the impact of the. I think the question is about the impact of the interventions. Maybe we need an additional analysis to know if the impact of each intervention in terms of life saved. Maybe we can analyze further our data, how much lives can saved by mobile and the nutrition team and by PIRI. I think it's enough.
Okay, let me look at the returns. The first question is looking at return on investing on outreach. When you conduct outreach session this year, next year, what happens? So when you conduct outreach this year, that means when you are able to reach the children, the unreached, it has ruled out vaccine hesitancy. It has ruled out not being willing to receive vaccine, but it's now looking at the ability to pay. So what happens is that next year the program of immunization will target ability to pay, getting these children, because in most instances when you look at you will see that people talk about vaccine hesitancy, talk about not being willing, but with outreach you see that caregivers will bring out their children and you immunize them. That means they are actually ready to get immunized, just that because of how to reach areas. In that context, the Kaduna, they actually their households are far from the health facilities, so and most of them are in hard to reach areas, so that's a major issue. So when this year you can vaccinate them, more people, even let me say this, this outreach, it also makes other people, even those households who are not willing to get involved, because they will see the effect of the vaccines by the effect of vaccine on the children of their neighbors, because they are not being vaccinated, they may not even know that we have results from vaccination. So that is it. So it's something that you continue and inform government to do something on ability to pay. Thank you.
Thank you. So from the first question, what was the zero dose defined? In measles, those are the measles vaccine less than 24 months, but for other vaccination, those children are missed less than 1 year or 12 months. What was the health impact? Yeah, the health impact is daily in the year of life lost as well. The health impact of zero dose, for example, in measles, there is a lot of days in the illness. What is the shared cost? We estimate the shared cost based on, for example, for personnel, we estimate exact time used for measles, zero-dose vaccine based on the time motion studies. Exact minutes to invest for zero-dose measles vaccine, not all. So we estimate based on that. For other supply costs, for example, for safety box contain a 115 syringe. We estimate only for one syringe per measles vaccine dose. So each supply personnel in the capital cost also share, and the capital cost also anti and based on the inflation rate in the lifespan. Thank you.
Thank you so much. There was a question about the cost of the drone. Yes, what we used from supported by literature was 60,000 US dollars, and then we amortize it to the quarter. That's the 20 quarters, looking at a life period of 5 years. So that's what brought to a quarter cost of about 3,000 for a drone. But also included costs of having this registered, the training of the pilots, the daily operational costs, and things like that. Thank you.
So, on the last question, how zero those children identified? Somebody asked that. Yeah, in Nigeria, we looked at zero those children as those children that has not received Penta 1 after 12 months. So once you are, because you're supposed to receive the first dose of the Penta vaccine at 6 weeks. So once you get to 12 months, you have not received it, you are categorized as zero dose. So I think the age of the child at the point of vaccination, and it identifies who's zero dose or not. Thank you.
Yeah, just chime again. So it seems like there are different definitions of what zero dose child is, and this could be antigen specific. So it could be penta, DPT, or it could be measles. And another challenge we are facing is that the definitions actually differ by, so different partners have their own definition. Gavi has its own definition. So sometimes it's a dicey situation, but Gavi defines the zero dose child as someone who doesn't have Penta 1 between 12 to 23 months. But in our study, the immunization program just looked at all children less than 5 years. So there can be some methodological limitations in that aspect. But regarding the birth cohorts, as my colleagues have said, the zero dose burden is a moving target. So even though outreaches are conducted, let's say twice or once a year, even when we go back, there will be new children to vaccinate, partly because of the contextual factors, such as many mothers give birth at home. So these children are actually systematically missed by the health system. So the outreaches actually help go to these particular hotspots in order to immunize them. And so in our case, the outreaches really worked in reaching these children who are systematically missed by the health system. And about the vaccination, the VPDs, we haven't yet conducted. I think it's too early to comment on this, and perhaps in a year or so we would be able to comment on the impact of these vaccinations. And lastly, the attribution for immunization, I think, is one of the key issues with integration with other health programs and immunization as well. But in our study, we tried to estimate the vaccine-related costs specific to the different antigens that were administered during the campaign. So this actually helped to reduce the cost a bit. But if the outreach is specific to that particular zero-dose child that doesn't have other antigens that are being administered during the campaign, of course, it will drive up the cost.
Okay, so very great answers to questions, but I think some of our questions remain for you. How do we rationalize the common understanding of zero-dose children? If you've got something to contribute on that, please let us know. See, there's a question here and then one in the back.
Thank you. I am Palwasha Anwari, consultant in the WHO EMRO. Thank you for great presentation. My question is specifically for the with regards to zero dose is either they are inaccessible or there is vaccine hesitancy. And these estimate or averages, do you factor that community mobilization and also awareness to tackle the hesitancy to reach them, and how will be the average cost if we compile that activity immunization with the community mobilization? Thank you.
And over here, and then I've got you too.
Simon Proctor, London School of Hygiene and Tropical Medicine. Thank you for the interesting talk. So, I have two questions, if I may. So, first question I think is a bit linked to Brian's question. I wondered, do any of the studies that you've done have data in it that might allow us to look at how the marginal cost of reaching zero-dose children is varying with coverage of the underlying routine vaccination in the population? Because presumably, if we've got higher routine coverage in the population, then that marginal cost is going to go up, and it'd be interesting to know how that varies. And then my second question is just back on the for the cost effectiveness analysis that was looking at the DALIs averted for measles. Does that account for kind of population transmission and immunity in the population, and how the age distribution of the doses that are being received by the zero-dose children are distributed? So, you've got to imagine that older kids are more likely to have maybe already had measles infection in the population. So has that been accounted for, or do you have plans to do that? Thanks.
Thanks. Hi, I'm Catherine Pitt, also from London School of Hygiene and Tropical Medicine, and was hoping I could get away with two questions. The first is probably relevant to a few of the presentations, which is about understanding better on a practical level when you arrive in a household with a zero-dose child. Do you then check all the other children and vaccinate them as well, keeping in mind that there might be older children who are perhaps under-vaccinated or behind, but they're not zero-dose? Or do you just ignore them and you're actually only vaccinating the zero-dose children and leaving other children in the same household not vaccinated on that trip? The other question was about the drones, and could you say a little bit more about their capacity, how much they can carry, and if they're only being used for vaccines? What about other essential health commodities, antimalarials, other drugs and things? Are they being used for that? Should they be used for that? And how practical is it? Thank you.
Hey, why don't you take those three? Let's get your microphone, and then we'll come back to the audience for more.
All right, I'll just start us off. So regarding mobilization and hesitancy, so that in the Uganda case study, the village health team members actually conducted some sort of mobilization when they were registering the households, but because of short timelines, they were not able to go back to these households which are resistant to vaccination. So certain attempts were made, for example, involving the local leaders and other leaders in those villages. But for some, they were successful, some were not successful. So I think you raise a critical point in terms of how much effort is required in convincing these households to vaccinate their children, and this cost was not covered. So it's a limitation of the study. Then there was also a question about the marginal cost versus the coverage of routine immunization. And in our study, we saw that in one of the districts, there was quite a bit. There was a high cost of implementing the intervention, but we saw that even with the investment, there were very few children who were actually vaccinated with DVT1. So I think this speaks to your comment, and indeed, the cost will increase if the number of zero-dose children decreases. And then lastly, how did we arrive to a zero-dose child? Did we check whether other children were under-immunized? Yes. So we found that where there's a zero-dose child, the probability of having another zero-dose child in that family is very high. Secondly, the probability that other children are under-immunized is also very high. So those two move together. You might find another zero-dose child or another under-immunized child. And so we try to link them to care, but sometimes it doesn't always work. It depends on the caregivers' beliefs in immunization as to whether they should take their children for immunization. So even though these families are linked to care, sometimes it doesn't. They don't seek immunization services as we would have hoped.
The hesitancy and the community mobilization. So in our study, intensifying community mobilization is part of the strategy, part of the vaccine delivery strategy, where they engaged more community volunteers to engage the community to mobilize them for the vaccination. So it's part of the disease drop strategy. So, but we did not consider looking at the cost, that is the incremental cost between the past community mobilization and the current one. But the cost of community mobilization is integrated in the total cost of the vaccine delivery. Thank you.
Thank you. Go through how the DALI was measured in these studies. So we measure the DALIs based on comparing these two strategies. The DALI was, as you know, year of life lost in the year of life disabilities. So we compare the vaccination, those are taking the vaccination, prevalence of the measles in the days from immunized in the non-immunized, and the illness from immunized in the non-immunized. The study is from different perspective, from global burden of disease in the systematic review. We're searching for low and middle income countries and Ethiopia as well. And we input the probability in the model. Then we compare these two strategies. Thank you.
Thank you so much. Maybe before I come to the drone question, I participated as a national supervisor in the catch-up study that Carol worked with. And just to add up, someone asked if they only focused on immunizing children, as well as children within the definition of up to the second year of life. Well, the registration was, the big catch-up looked at imagine up to about 59 months, that is less than 5 years. So if there was a child who had missed the vaccines, they were given during the sessions to be catch up. So getting to the drone, you asked for the capacity. We modeled the capacity of it was drones that could carry up to 15 kilograms, and that is approximately 3,000 doses of DPT vaccine, and to the distance of about 150 kilometers. As you also asked if specifically these drones will be used only for vaccines. Yes, we modeled just for vaccines, the child vaccines to these remote islands. But well, The traditional method carried both medicines and vaccines to the district vaccine stores. So there is that cost difference that the traditional method carried more than just vaccines. Thank you.
Thank you so much. I would like to reflect on a couple of questions. So the first question regarding zero dose, as due to inaccessibility or distance, or whether it's hesitancy. In our case, we argue that it's the distance, it's inaccessibility, and not only in terms of really reaching to the vaccines, but also in terms of uh, understanding what the benefits of vaccines are. These are really remote areas, and people may not know much really about vaccines. If they knew, they could maybe, meet halfway in terms of cost because they will be reaching out to facilities. So I think we have to do a better job of really informing what the benefits of the vaccines are, and also trying to reach out to the communities that are very remote. Uh, yeah. And the other one is obviously there would be a varying cost if you have, say, a higher coverage area and comparing to a lower coverage area. So the lower coverage is for a reason. It's probably because it's unreachable, which would be expensive. We didn't really get the opportunity to really look at these specific areas and compare them, as we only focused on remote and nomadic region. But I would argue that the higher the coverage, the higher the cost of reaching zero. It is big. Thank you.
So let me repeat what you just said. The higher the coverage, the higher the cost of reaching zero dose children. That's interesting. I get it. Because you've gotten the cheap ones already, and as you get higher and higher, who's left? The most expensive. Interesting. Okay, I got a couple of questions. I got Mark. Oh, I got a lot of questions. Let's go take four, and we'll hit the ones in the very back, and then we'll come. Brian's already got one. We'll get in last. Mark?
Thank you, Mark. New York University. I'll keep it to one less than 70 questions, which is actually the comment that David made just a moment ago, which is that what we expect is that, there's diminishing returns. If you get too hard to reach people, it costs more. But hearing from the range of talk, some of you presented modalities for reaching hard to reach or zero dose children that seem to be actually more efficient than the existing system. So I think it'd be really interesting if to understand of all the sort of different sort of options present or strategies presented here, which ones are actually more efficient than current immunization systems? That means it actually costs less per child reached. And therefore, it's almost like no-brainers. These are extendedly dominating what we're doing right now. We should definitely do them. And which of them would require actually being willing to pay more to reach those people who, well, probably on equity ground that might even have a higher burden of disease or maybe disadvantaged in other ways, but we will still need to be willing to pay more per child to reach.
I think right in front here.
Yeah, thank you so much. Mothers bring forth children. So I would like to know the health security behavior of pregnant women and how to reach them. Thank you.
Was there another one in that corner? I got one here, and then Brian. Here, there's your microphone.
Thank you. My name is Anita. I'm from Bishai. The question is for Uganda, where you did the household identification. Keen to understand what kind of data sets did you use? Were there existing household line listings or community mapping do you leverage for this registration? And then is it a valid assumption that given you've done this mapping in a given district, the future cost of identification goes down because you have a better understanding of how to target based on the probabilities of zero disease?
Thanks, Anita. So using geography, spatial patterns that you know again and again, that zero-dose child is not a property of a child, it's a property of a place. That knowledge can drive down the costs, right? I've got Logan and Brian. Can I come back to you next round? Okay.
So on the first question, which strategies, efficient? Looking at them, they all look, relatively equal. But then again, in the case of PIRI and the mobile health and nutrition team, you're going out there to look out, for zero dose children, and more specifically, in the case of PIRI, it's immunization specific activity. If you look at other strategies, it's that the large chunk, around 65% of the cost goes to opportunity cost, which is like, people share services. So those strategies are specifically targeting zero dose children. You are mobilizing communities and really going out of your way, organizing health facilities and going outreach. And maybe that's the reason that the cost looks a bit efficient, I would say. The same is true for mobile health and nutrition team. And the interesting aspect is they provide a package of services, specifically maternal and nutrition services. But then again, the issue would be like about sustainability. In Ethiopia, in our case, this program is being funded by UNICEF. And what if when UNICEF stops funding? It's an issue. Again, it is dependent on vehicles, which are really expensive. And in Ethiopia, if your car crashes or something happens to your car, the car will be in a garage, say for a month or 2 months. Then look at what's gonna happen in terms of vaccinating and delivering the services. So it's a complicated situation, but those strategies are specifically targeting hard to reach areas. That's why they a bit more less costly.
So if the which of the strategies are now is now cost effective, more cost effective. So we are looking at how to reach areas. So it may have more cost, but when you try to get the unit cost of reaching those children, they see it's cost effective. That is why we are saying that using outreach to reach those children is cost effective. Because because they are held in these areas, if you go to the health facilities, you see that they have very low coverage, meaning that there are so many children out there waiting for vaccines. So when you spend more money to get those children, by the time you quantify the number of children you reached and the fund invested, you see that it is it is more efficient. But on the other hand, if government is able to, because we have seen that with little effort on social mobilization and health education, you see that people are willing to receive vaccination. So if the government will have these health facilities closer to households, like if you go to hard to reach areas, you have health facilities scattered in those areas that will be very close to the household, so that they will not spend additional money in transporting themselves from their homes to the health facility. Then outreach may not be there again, and children will be covered. So it's just because it has to do with transport. Because if you look at the cost, majority of the cost will come from transportation. transporting health workers and vaccines to those outreach stations. So the same thing, if you did not transport vaccines to those outreach stations, then mothers transporting themselves from those areas to the health centers becomes another problem. And you see that the cost of transporting health workers and their vaccines to those stations, if you compare it with the cost of different households spending money to go to the health facility, then you see that it is cost effective to reach them instead of allowing them to borrow money, and they will be very impoverished because of that. They may not eat because they will go for vaccination. That will be a very big damage to the health system generally. Thank you.
Just quickly on the registration. So the registration exercise used sort of like a line list, you might say. And it had different parameters. It had child's name. Sorry. It had the name of the child, the village they are residing in, the caregiver's contact. So it's quite detailed. And we've seen that the ministry is taking this on due to the challenges of the current DHIS2 system, because the system doesn't give disaggregated data. So they're using this as kind of like a basis at community level to identify these children where they are, and it has really helped. However, its sustainability is not clear, because it is reliant on village health teams who are voluntary. I mean, they work on a voluntary basis, but during this exercise, they were given some incentives, even though the incentives were not enough, but they were incentivized to actually register these households. As to whether the cost will decrease over time, I'm not sure, because in the beginning, it requires a lot of money to in terms of per diems and personnel time for these VHTs to move house to house. However, perhaps in the future it could decrease, but I'm not sure. I'm not optimistic, because we need to incentivize the village health teams to continually update the register. So it's not a once-off, because once you register a child in July, you need to go back and update the register whether they got the vaccine, but also update it with the new birth cohort. So it's one of those situations which is unclear at the moment. Perhaps it needs to be studied further.
Thank you. And maybe just add on that, most of these verifications will be done on dated paper or an exercise book. And as we speak, there are probably some those facilities that have lost these records. So you want to have a system that will retain this registered children, so that at least you have the best. If you're adding the next back cohort, you at least have where to add to a top up kind of. That's when we can see costs. But we see a situation where if we're having a similar campaign, we'll have to redo the whole thing of registering children, because we didn't really, it wasn't an electronic system, it was a paper-based, and we know the challenges. Sometimes there are actually some villages that didn't receive the materials to register, and it's kind of a challenge. And she said it's really not optimistic about how to reduce the costs going forward. But I think there's a question that was asked about the health-seeking behavior for pregnant mothers in hard-to-reach areas. Well, again, this is, I would want to say that it gets a bit difficult in like a district. Overall, for Uganda, we see an improvement in facility deliveries, over 80%. And that's a good sign. ANC, we have up to 8 ANC visits, and we see this increasing, and it's an indication that seeking behavior from pregnant mothers is actually improving. But then when you look at contextually, you look at a district like Bogoma, it's submerged in water. Like I've told you, it's 52 scattered islands as a district, and about only 9 of these satellite islands have those facilities. It leaves the rest over 30 depending on outposts and outreaches from these health facilities. So sometimes it's the PHC funds that are budgeted to reach to these satellite islands without health facilities. Like they're supposed to go like 3 times in a quarter, but because these inadequate funding, sometimes they go once in a quarter, sometimes they don't even go. So contextually, there could be willingness to seek these services, but then the cost to reach the host facility, because it's the main island with the health center for which provides bulk services. But then to reach there, you probably, if you're in a certain island, kilometers away, you need to hire boat. Much as government provided ambulances, it's costly for them to fuel and get these mothers to seek these services. But overall, when you look at the indicators they talked about, the university behaviors for pregnant mothers is improving, but it's so much constrained in these hard to reach areas due to that. Similarly with vaccination, the mobile communities, for example, these are fishing communities, so they keep moving from one area where there's a better catch to the next, and much as there's an almost settled and village, there's so many children on this, and you want to follow up with these children to receive the next dose of probably 2 or 3, but then there's no funding to go back there, or you go back and the community has moved to the next fishing village and something like that. So these are the contextual challenges that we see, especially for Ireland.
Okay, so talking about health behavior of mothers in hard-to-reach areas, I have some concerns about it. Because when you talk about health-seeking behavior, you first of all look at availability. So, when you say that how to reach area, because I will tell you they face informal health care services. But the reason is not because they want. The reason is because that is what is available. So should we now call it health-seeking behavior? Because if they have access to formal health services, of course the behavior will change. Because they don't have that access, they are looking at what is available. So that's why I have some concerns about the way we estimate the health-seeking behavior of hard-to-reach women, because I believe that the major factor is the availability. Which one is available to them? So if we want to look at it, we first of all look at the available options before we now think about where do they go when they have issues related to health. Thank you.
Okay, so I had Brian and Logan. Can you ask your questions to the panel after the session? There are about 5 minutes left, and I wanted to sort of have some wrap-up statements from our panelists. I've gotten a lot, I know you've gotten a lot from today. Things that have come together for me are that we have cost-effectiveness guidelines. The CHEERS checklist was informing some of their work, and here I'm just reminding everybody that our group, immunizationeconomics.org, has a lot of guidance, and I hope you'll cite these references, but I hope you'll also say, what we're doing with zero-dose children needs extra guidance on the definition and how we do costing. There's something extra, and that extra thing really comes up in this rural panel, where there's a zero-dose child place. There's a hard-to-reach place that is defined in rural health economics, because the next hour will be urban, where it's really maybe a zero-dose building or a zero-dose street, but not like what we're dealing with, which is a geographical economic backwardness. And that comes to our last point, which is what happens in our field is fragmentation. we get stuck in our little bubble of immunization economics with EPI programs with their budgets, and we do cost effectiveness for the EPI program. And we look at our budget envelope with the resources of the EPI program, and we buy drones for the EPI program, and we don't rent them to anybody else. And honestly, the drone cost would go way down if you could rent your drone to anybody else who needs a package sent to the island. Then you'd be making money. You'd actually be positive because you'd be renting your drone, 29 days out of the month. Back to the other point, which is the registrations, right? So why is it EPI's problem to register every child? It's the public health department's problem to register every child and to keep the community health program going in those hard-to-reach places. So if they would do that, then we could take advantage of that. And the spin-offs are immense. The children need just vital registration, but they need growth monitoring, nutritional interventions, sanitation, and so on. And so if we could think broader in our field and not say, well, we're this little community of EPI, and we have our own problems. Our problems are spreading out, especially in this zone of zero-dose places. So going forward today and the rest of our year, let's think of expanding zero-dose children to hard-to-reach place definitions. What prevalence of zero-dose children would be a cutoff? I would love to see a spatial map, a heat map of zero-dose children in these countries, as whatever data sets you get from EPI permit that. Where are the hotspots, and what could we do to the entire hotspot to bring down the cost, as opposed to whatever we could do for the child? So I want to give you any last wrap-up comments, and then we'll close and go on to our break. Wrap-up comments?
All right. So for me, the key would be in those hard-to-reach areas. What are the really efficient way of reaching, especially in remote and resource-limited areas, right? Like in Ethiopia. So if you think of building health facilities everywhere and then, fill them with stuff, you end up paying more than you get anything done because the community is moving around. So the importance of thinking about efficient systems such as mobile health and nutrition team, which package a lot of services together and try and address communities in different areas is important. So that is, I think, an important, point to think about. Thank you.
Thank you so much. First, I want to thank the association for an opportunity like this. And to me, the last message is that we all come from different contexts, trying so many ways to reach the children. And I think this presents an opportunity for us to exchange ideas, to discuss and see what one area, one country, to our own context, because it's really a challenge that we see much as the government and implementing partners are supporting the number of zero-dose children still continues. Probably drone deliveries work better, and there are ways that has worked in your country. I think this presents an opportunity for discussion and us to find a way forward to reduce zero-dose children in our communities, especially in the hard-to-reach communities in our countries. Thank you.
Thank you. So zero-dose children is highly contagious for community by itself. To address this, support the routine catch-up is important because the scarce in resource. And this routine catch-up is a component of routine immunization in day-to-day activities rather than the campaign as well. So support the healthcare workers, especially health extension workers, important to address these zero-dose children to effective management of the immunization vaccine. Thank you.
Thank you. How to reach a session is going through the option for reaching zero-dose treatment and its cost-effective but having more health facilities that will be closer to the households in hard-to-reach areas, I think it will perform wonders because they will have access to other health care services. Thank you.
Zero dose is a moving target, and we need targeted, data-driven approaches. So we need to know where this child is, first of all, before we go vaccinate them. Registration can identify these children, however, its sustainability is unclear. Thank you.
Thank you very much. And you can go back to your seat, and we want to give you a round of applause.